Welcome to the NCLEX Crash Course. In this series, we'll cover topics like pharmacology, medical surgical nursing, pediatric nursing, obstetric and gynecological nursing, and psychiatric nursing. Don't forget to subscribe for more valuable NCLEX Crash Course episodes.
In this video, we are going to discuss some more important major disorders of gastrointestinal system. So I hope you are enjoying all the wonderful sessions, and we have almost covered half part of the disorders. We have started from the oral cavity, and now we have covered almost the stomach part. And here in this video, we are going to cover some more important organ and their diseases. First, let's start with the cancer of the liver. So you can see here, this is a liver which is affected by the cancerous tissues or cells. Now, let's see why cancer of liver occurs, what is its etiology, and what is the nursing care that we have to provide to these kind of patients. So first, let's see what is the cancer of liver. So cancer that begins in the cells of liver will be called cancer of the liver. Talking about etiology, it may be primary or metastatic, which means it may be primary, that it is developed from the liver itself, or it may be metastatic. It means that it was spread from the other organ. It can be primary carcinoma. It means hepatocellular cancer or hepatoma. It means that the primary carcinoma is where the cancerous cells develop from the liver only. And this is rare. Okay, so these, primary carcinoma of liver is rare. Contributing factors. So what are the factors that can contribute to the cancer of liver? So it can be hepatitis B infection, hepatitis C infection, and cirrhosis. So we have discussed in our previous video that cirrhosis means there will be degeneration of the liver. There will be fibrous tissue development, and this will lead to the degeneration of the tissues of the liver cell, and that can lead to the dysfunctioning and damage to the liver. So that damage can build up, and that can lead to growth of the cancerous cells. Alcoholism. So alcoholism, which is chronic, can cause toxification in the liver, and liver may not be able to metabolize that, and further it can damage the liver and can lead to the cancer. So these all are the factors. For example, hepatitis B and C, cirrhosis, alcoholism, and other is anabolic steroid use. So it is also seen that anabolic steroids used by many people, especially who do the workout and build up the bodies, will be seen having these kind of cancer. Next point is lack of bile causes inadequate vitamin K absorption, resulting in deficient prothrombin synthesis and subsequent bleeding. So this will be also seen here. This is the pathophysiology, that when the liver will be damaged, so lack of bile will cause the vitamin K to decrease. Its absorption will decrease. This will result in deficient prothrombin synthesis. So prothrombin is very important when we talk about the clotting function. So it disturbs the coagulating power of the blood and can lead to subsequent bleeding. Liver cancer has very poor prognosis. So once you develop the liver cancer, it is very rare that you will be reversed to the normal physiology. Next thing is the clinical findings. So what we are going to see in the patient having liver cancer. So if you talk about the subjective data, the patient will report anorexia. So as we have discussed in all the disorders of gastrointestinal tract, the first thing the patient will, feel that will be anorexia. So loss of appetite will be the first thing that the patient will feel. Second is ache in the epigastric area. So it is, obvious that when there will be cancerous cells, this will lead to the contractions, and that will lead to the ache in the epigastric area that is close to the liver. Weakness will be felt. So due to loss of appetite, malnutrition can occur, and weakness and fatigue can occur, and malaise also. So these are the subjective data that the patient will report when he will come to the hospital. Now, let's see what is the objective data. What we are going to investigate, what we are going to assess in the person. So if we observe, if we assess the patient's condition, so weight loss will be seen. There will be bleeding. So patient may report, bleeding from the wound very frequently. If patient has any wound, so it will not clot properly. If there is a small cut on finger, so that will not heal. That will not heal. So this will indicate that patient has bleeding, which is not healing. Fever. So fever can occur because in cancer patients, fever is very common as to provide immune response by the body. Anemia will be seen because bleeding will occur, so loss of blood can lead to anemia. Jaundice will be seen. So as there will be liver dysfunction, so bilirubin will be not able to process and the physiology will disturb. Therefore, the bilirubin will accumulate over the skin. So we will see the discoloration of skin. So yellowish coloration of the skin will be seen on the nails and in the sclera. Ascites. So ascites means there will be accumulation of fluid in the abdomen. So this will be also seen because when liver is damaged, so sodium levels will be decreased. So that will lead to development of the fluid in the body. Increase the serum bilirubin level. So obviously when liver is damaged, bilirubin level will increase. We will see increased alkaline phosphate level. So ALP will be increased. That is SGPT. This will be increased. Confusion. The patient will be seems to be confused. There will be lethargy, low extremity edema. So all these are the clinical findings that we will observe in the patient. So the basic findings will be that there will be fluid retention, that is edema. There will be weight loss, and weight loss will subsequently lead to the fatigue, lethargy, etc. And related to the liver, there will be increased bilirubin level. So all these things will be seen. Now, talking about the therapeutic interventions, that how we are going to manage the patient. So as the patient is having cancer, so palliative interventions will be applied here. We have to provide the end disease care to the patient. So for the patient having cancer, the thing that is important that is commonly done is hepatic lobectomy if tumor is confined. So as we know that liver is divided in the, so if we see the liver, so it is divided into the right and left lobe by the falciparum ligament. This is the falciparum ligament, and this is the coronary ligament. This is the falciparum ligament. So it is divided into the right lobe and the left lobe. So if tumor is confined to one lobe, so that lobe will be removed. So that will be called hepatic lobectomy. If the tumor is confined, it means it has a specific shape and it can be removed. Can be done by laparoscopic resection. So we can do this by the new procedure, that is laparoscopy, in which the endoscope will be used that will guide the physician or surgeon inside the body, and the tumor will be removed from the laparoscopic procedure. Other thing we can do is liver transplantation. So this is the last option where we have to transplant the liver because it cannot be reversed. And for cancer, third thing that can be done is chemotherapy. So in chemotherapy, doxorubicin, 5-fluorouracil, that is 5-FU, darunavir, that is Prezista, ibritumab, tuxetan, that is Zevenil, and targeted drug therapy with sorafenib, that is Nexavar. So all these are the anti-neoplastic drugs. We can say that they are used in the chemotherapy to damage the cancer cells and to contract them. So chemotherapy can be done. If it does not work, so then liver transplantation is needed. Other than this, percutaneous infusion with cytotoxic drugs. So drugs that will kill the cancerous cells can be infused percutaneously. For example, fluorodeoxyuridine. So this can be administered. This is called FURD. This is very important in the percutaneous infusion with psychotoxic agent. Other than this, yttrium-90 microspheres and ethanol can be used for infusing the cytotoxic drugs or agents by the percutaneous route. Other management we can do is radiofrequency ablation, cryosurgery, immobilization of blood vessels supplying the tumor, injection of alcohol or anti-cancer drugs into the tumor. So sometimes we can directly target, these are the direct method to target the tumor cells. So in this, radiofrequency agents can be used. We can do the cryosurgery where we will damage the tumor cells by the a small current or electric shock. Immobilization of the blood vessels, we can immobilize the blood vessels supplying the tumor. We can inject the alcohol or anti-cancer drugs direct into the tumor. So all these things can be done. Photodynamic therapy. So what is photodynamic therapy? It is a photosensitizing drug and laser light to destroy the cancerous cells. So here, as the name indicates, the light will be used, that is laser light will be used to destroy the cancerous cells. And external radiation therapy. So as the traditional method, we can do the radiation therapy from the outside. Now moving on to the nursing care of clients with cancer of the liver. So from the nursing care, what are the things that are important? So first thing is assessment. So when the patient comes with the cancer of liver, first thing is we have to collect all the details, we have to collect all the history, the cause and the contributing factors, so that we can provide diet according to that, we can provide education according to that. So first thing, we will assess the weight. So we have to weight the patient to assess ascites. So we know that if there is liver dysfunction, then the swelling can occur, the ascites can occur. So we have to check the weight. If the weight has increased and it is abnormal increase, so this can be due to ascites. And we have to check the nutritional status of the patient. Then we have to check the patient's skin for jaundice. So we have to check the nail beds, we have to check the sclera and the whole body for the yellowish discoloration of the skin. Second thing, we will ask for the bleeding. We can ask that if patient has bleeding from the nose or from the stool, if melena is there, or any kind of bleeding, any kind of injury that is not healing, that all we have to ask. And other is pallor. So pallor, if present, it will indicate anemia. So that we, from these history, we can know if there is damage to the liver and what is the cause. Then third point is presence of dullness when percussing over the liver. So the liver will be, there will be dullness. It will be not dominantly palpated. So that thing we will observe. And there will be ascites as mentioned. We have to ask a detailed history including exposure to any causative agents. So as I mentioned that we have to ask the patient that what were the contributing factors. If patient was alcoholic or if patient used the anabolic steroids, all these things we have to ask. Now moving on to the planning and implementation. So for this patient, what are the planning and how to implement all these planning. So when the patient is admitted with liver cancer, first of all, we have to achieve the short-term goals. So always achieve the short-term goals first. So it is obvious that when patient will come, then he will complain of the pain and discomfort. And the patient will complain fatigue, anorexia. So we have to combat these things first. So we have to provide for comfort and pain relief. We have to help to combat fatigue and conserve energy. So our goal is that patient feels comfortable, patient has no pain, and patient feels more energetic. So we will provide a complete bed rest so that Patient will conserve the energy. We have to be available to both client and the family members to discuss their feelings. So as we know that cancer is a disease in which there is a lot of stress, a lot of pressure on the family members. There's a lot of grief, and sometimes patient is not able to accept. Patients have do not have enough knowledge about the condition, so we have to be always available to the client and the family members so that we can resolve their doubts. Third is we have to maintain fluid and electrolyte balance, and we have to monitor the input and output of the patient. I hope you know about the physiology why ascites occur, why fluid level increase, that is why fluid disturbance occur. But if you don't know, I'll give you a short review here, that whenever there is liver damage, suppose a patient's liver is damaged. So what happens? The portal vein pressure increase. As the liver is not able to take the blood supply, so what occur here is that the portal vein pressure increase. So when the portal vein pressure increases, so this lead to increase in the veins. Okay, all the other veins pressure will be increased, and this leads to the low blood levels of protein called albumin. So albumin protein will be decreased. So albumin is very, very important for the fluid maintenance. So when the albumin will be decreased, so that will disturb the fluid electrolyte balance and will lead to the ascites. So this we have to remember. Next is we have to observe the client findings of bleeding esophageal varices. So as we have discussed in our last video, when there will be increase in the portal vein pressure, then this will lead to the increase in the pressure of the esophageal veins. And that pressure increase in the esophageal veins can lead to esophageal varices, where the vein pressure will increase, and these veins in the esophagus can rupture and can lead to bleeding. So we have to observe the clinical findings for bleeding and esophageal varices. We have to ask the patient for hypoglycemia. As patient is having a lot of metabolic dysfunctioning, then we have to ask everything. And we have to ask for other metabolic dysfunctions resulting from impaired liver function. So we can see here that liver is very, very important for everything. It is important for the clotting. It is important for the metabolism of the glucose and everything. That's why when it damages, we have to combat every problem. We have to encourage the client for coughing and deep breathing and changing positions frequently to prevent pulmonary and circulatory complications. So when liver damage occurs, the circulation is impaired, the portal vein pressure increases, and this leads to the ascites. So as we have discussed in our previous video, when there will be ascites, then this will lead to the diaphragm. The diaphragm will have some pressure, and this can lead to the breathing difficulties. This can lead to the dyspnea. Therefore, we have to encourage the patient for coughing, deep breathing, and we have to tell the patient to change the positions frequently so that the respiratory system functions well and all the circulatory complications can be prevented. Next, we can implement care associated with chest tubes because thoracic cavity may be entered during hepatic surgery. Now, this is very, very important here in the relevance to the nursing care. So when we are with the patient who had hepatic surgery, so that patient will have chest tubes. So when we are trying to get in the body, when we are providing incision, so incision is done on the chest wall for hepatic surgery. So patient will have chest tubes. Okay, the patient having hepatic surgery will have chest tubes. So we have to provide the care associated with the chest tubes because thoracic cavity may be entered during the hepatic surgery. Okay, so these things we have to keep in mind. We have to make sure that the chest tubes are placed well, they are not kinking, and there is a proper flow, and the dressing is intact. Next is the evaluation. So, what outcomes we expect at the ending when we have done all the medical management, all the nursing care we have provided? Then, what is the thing we have to evaluate? We have to evaluate that patient verbalizes feelings about diagnosis and prognosis. If patient is verbalizing the feelings, if patient is talking about the diagnosis, if patient is able to accept the condition, if he wants to know about the prognosis, it means that he has some kind of that insight of the disease and he's accepting the condition. So makes us it makes us confirm that yes, patient has a mental stability. Next thing is that a patient maintains fluid balance. So this is very important here. If patient maintains fluid balance, it means that the circulation is proper, patient remains comfortable. So this is will be our first goal. And patient remains free from injury related to the altered coagulation. So we have to keep in mind that we have to prevent injury. We have to remove all these sharp objects. We have to provide comfortable shoes to the patient so that patient remains free from the injury. So providing comfortable shoes, and other than that, we can, if patient wants to do some kind of activity, so that those activities should be very quiet activities, like playing indoor games, like playing Ludo. All things will be done. So these things we will evaluate. So this was all about the cancer of the liver, where we saw that what is the cause of the liver cancer and what occurs after liver cancer, what is the prognosis, what are the clinical findings that patient will report, and that we will assess. And we talked about the medical interventions, that about the chemotherapy, about the radiation therapy, about the infusion of cytotoxic agents, about the radio frequency ablation, cryosurgeries. Other than that, we talked about the hepatic lobectomy, we discussed about the liver transplantation. Then we discussed about the nursing care, in which we assessed the patient for ascites, for jaundice, for bleeding, and we percussed and we included all the history of the patient. Then we did the planning, where we are providing comfort, we are consoling the family members, we are maintaining the fluid and electrolyte balance. We observe the client for bleeding and all the things related to the bleeding and metabolic dysfunctions. And we encourage the patient for coughing, deep breathing, so to maintain the respiratory circulation, respiratory function and circulation. Other than that, we provided care for the chest tubes, and then we evaluated all these things that if they were done properly. Now moving on to the next disorder or disease, that is appendicitis. So as the name indicates, it is the inflammation of the appendix. So itis means inflammation, and this is the appendix. So we can see in this image that this is the area of the appendix. This is the appendix where it has inflamed. So that inflammation of appendix is called appendicitis. Okay, so compromised circulation and inflammation of vermiform appendix. Inflammation may be followed by edema, necrosis, rupture, peritonitis. So, the appendicitis occur when there is compromised circulation, when circulation is not, reaching the appendix, and swelling of the appendix, and this inflammation can be due to the edema and necrosis or rupture or peritonitis. So if there is a rupture in the appendicitis, if there is peritonitis, and if there is edema, so this can lead to the inflammation of the appendix and further can lead to appendicitis. The causes of appendicitis can be obstruction by the fecality. So what is a fecality? This is the fecal matter which pass from the small intestine to the large intestine. So this can obstruct in the appendix, which can lead to the impairment of the circulation to the further part. If this is appendix, so if there is fecal matter obstructed, so circulation will be not able to pass to the other part, and this will lead to the inflammation, infection, and further complications. And this can be obstructed by the fecalate, foreign body, or kinking. So if appendix kink, so this can also lead to the appendicitis. Now, what will be the clinical findings? So in subjective data, we will see patient will report anorexia, nausea, right lower quadrant pain, that is McBurney point. So when we divide the quadrant, so this is the right lower quadrant. So when the pain will occur in the right lower quadrant, this will be known as McBurney point. So the point where the pain occur on palpation, so that pain will indicate the appendicitis. So that is the McBurney point. The other sign or point we have seen in the last video was the Murphy sign. We have seen about the Murphy sign. So if you recall, what is the Murphy sign? So try to recall it. I'll give you 5 seconds. Let's recall that. The Murphy sign is seen in the patient having gallbladder stone or cholecystitis. So if patient has cholecystitis, so Murphy sign is seen, and you need to see the video if you don't know about this. So you have to see the last video. So there will be anorexia, nausea, right lower quadrant pain, that is McBurney point pain, and rebound tenderness. So when we will palpate, there will be rebound tenderness. Talking about the objective data, so in objective data, we will find the complaints of vomiting. They will be vomiting, there will be fever due to the inflammation. Leukocytosis will occur because if there is some kind of foreign body, as we have seen here, if there is a foreign body present, so the body will try to provide the immune response. Body will try to fight with the foreign body, and WBC level will increase. So there will be increase in the WBC level, that will lead to leukocytosis. And abdominal distension and paralytic ileus can occur if appendix has ruptured. So if appendix get ruptures in the further time, so there can be paralytic ileus and the abdominal distension. Now moving on to the therapeutic interventions. So for patient having appendicitis, what is the management that we will provide? So surgical removal of appendix immediately to decrease risk of rupture and peritonitis. So if appendix rupture, it can lead to the peritonitis, okay, and it can lead to further complications. Therefore, the priority, the main thing is that we need to remove the appendix. This will resolve the problem, because appendix is not a useful organ. It is a rudimentary, organ which has no use. So if it gets removed, then there will be no, impairment or effect on the functioning of the gastrointestinal system. We can provide prophylactic antibiotics if we suspect infection, and most of the time we start the antibiotics prophylactically so that the infection can be prevented. We have to maintain the fluid and electrolyte balance, because if there is circulation impairment, so that can lead to fluid retention and can lead to the peritonitis. We can provide analgesics for the pain. So it is seen very commonly that patient reports a sudden pain over the right lower quadrant. Therefore, we have to provide analgesic for that. Moving on to the nursing care of clients with appendicitis. So what is the nursing care we can provide here? So first of all, we have to assess the patient properly. We have to see that what is the history of the patient. So we have to collect the history of characteristics of pain, nausea, and vomiting. When pain occurs, where the pain occurs, why nausea occur, and about the vomiting. Second thing, we have to ask the presence of anorexia or urge to pass the flatus. Okay, so if there is obstruction and if there is paralytic ileus, then we have to ask about the movement of the bowel. If there's urge to pass flatus, if there is anorexia, we have to ask. We have to ask for the presence of rebound tenderness. As we know all about the clinical findings, so we have to ask for all these symptoms about the rebound tenderness when palpating the abdomen. This will indicate that yes, there is some disturbance in the right lower quadrant. We have to check presence of tenderness, rigidity when palpating McBurney point, that is Robsing sign. Okay, so we can palpate the McBurney point for the tenderness and rigidity. It is located between the anterior iliac crust and the umbilicus in the right lower quadrant of the abdomen. So if we see, this is the abdomen, and if this is the iliac crust, so this is located between the anterior iliac crust. This is the posterior, this is the anterior. So it is located between the anterior iliac crust and the umbilicus. So here is its location. So we can palpate this for the tenderness and rigidity. We can check the temperature for baseline data. This will indicate the infection. We can check the presence and extent of bowel sounds so that to see the proper movement of the bowel. Next is planning. So what planning we can do for the patient having appendicitis? So first of all, we have to provide emotional support because in this condition is unanticipated and client needs to ventilate the concerns. So this is the first thing we need to see, that as in this condition, the patient is unanticipated, patient do not have enough knowledge, patient is not prepared for the things, patient didn't know about the condition. So we have to make sure that patient ventilate all the feelings and the patient emotional stability is regained. We have to provide the emotional support. Second thing is we have to monitor the fluid and electrolyte balance. So this is almost same in every nursing care of every GI disorder, because when there will be circulatory compromise, fluid and electrolyte balance will be disturbed. Therefore, we have to maintain that. Next thing, we have to assess for the signs of infection. We have to maintain semi-fowler position to help localize the infection in the lower abdominal cavity if appendix ruptures. So we have to assess the sign of infection by checking the temperature, and we have to maintain the semi-fowler position so that we can localize the infection or inflammation in the lower abdominal cavity. In semi-fowler position, it is easy to palpate, it is easy to assess the patient if there is rupture of the appendix. Next thing is we have to assess for the return of bowel function, because we know that appendicitis can lead to the paralytic ileus, and if there is paralytic ileus, then the bowel movement will be affected. So we have to assess for the return of bowel function. And how can we assess the return of bowel function? We can check the bowel sounds, we can check if flatus is present, and we can check if bowel movement is occurring. So for that, we have to encourage the ambulation. So this is the planning we will do. What is the evaluation and outcomes? So patient states that pain is alleviated and patient remains free from the infection. So these are the evaluation. So this was all about the appendicitis, where we discussed that how the appendicitis occur, what it can lead to. So it occur due to the compromise of circulation, it can occur due to the inflammation, it can occur due to the obstruction by the fecal matter by any foreign body or by kinking. Then we saw the clinical findings where the anorexia were the chief symptom, the nausea, pain, that is McBurney point pain. This will be very common system, and there will be rebound tenderness. In objective data, we saw a patient had vomiting, fever, leukocytosis, abdominal distension, paralytic ileus if appendix has ruptured. Then in therapeutic interventions, we surgically removed the appendix to decrease the rupture risk. Then we started the antibiotics prophylactically. Then we maintained the fluid and electrolyte balance, and we gave NLCEX for the pain. In nursing care, we make sure that we have assessed the patient well, we have checked all the history, We have checked the presence of anorexia, the urge to pass the flatus, the tenderness, and the rigidity of the McBurney point, and temperature for the infection. We have checked the bowel sounds. For planning, we provided emotional support. We maintain the fluid and electoral balance. We check the signs for infection, and we maintain semi-fowler position so that palpation is easy. We check the return of bowel function. Then we evaluated that patient is not complaining the pain anymore and patient infection is not present. The next disease is irritable bowel syndrome. So what is irritable bowel syndrome? It is a functional motility disorder of intestine. So here the motility function of the intestine will be disturbed. So here we have to see that this is not only of the disorder which is seen in the gut. It is also associated with our neurological system. What happens here that in this irritable bowel syndrome, it is a group of symptoms that occur together. It include repeated pain in abdomen and changes in the bowel movement, which can lead to diarrhea or constipation, and there will be no visible signs of the damage. So basically, there will be no visible signs. So if patient goes for the X-ray or ultrasonography, so there will be nothing reported in those tests, but patient will be complaining, that fullness and that burning, all these symptoms the patient will be complaining. But the main thing is that patient will be not able to find out that what is the main cause of the condition. Now, the cause of irritable bowel syndrome is unknown. We cannot actually tell that why irritable bowel syndrome occurs, but we can tell about the precipitating factors. So possibly it is related to the serotonin associated with the neurological hormonal regulation. So it is related to the serotonin, which is associated with the neurologic hormonal regulation. It can relate to the vascular or metabolic disturbance. It can be due to infection, irritation, heredity, psychological stress, depression and anxiety, high fat diet. So nowadays, irritable bowel syndrome is seen in the youngsters due to the high fat diet, irritating foods, alcohol consumption. So all these things can lead to irritable bowel syndrome, but exact cause is unknown. It affects approximately 25% of population, which is quite high, and it affects women than the men. And the thing here we have to see is what the patient will complain and what we will observe in the client. So if we talk about the clinical findings, so patient will complain left lower quadrant abdominal pain. So if we divide the quadrant, so this is the right upper quadrant, this is the left upper quadrant, this is the right lower quadrant, and this is the left lower quadrant. So pain will be seen commonly in the left lower quadrant, that may be precipitated by eating and or relieved by defecation. So the patient will complain that whenever patient eats, the pain occurs and it will be relieved by the defecation. There will be a lot of bloating, abdominal cramps, and dyspepsia, that is indigestion. So basically, when patient will eat, food will trigger all these things. And if stomach is empty, so all these symptoms will be reduced. In objective data, we can find constipation or diarrhea or combination of both. Abdominal distension can be seen. Barium enema and colonoscopy may indicate spasm or mucus accumulation in the intestine. So it may indicate sometime that there will be mucus accumulation and spasm in the intestine. So that spasm will lead to the pain. Now moving on to the therapeutic interventions. Now moving on to the therapeutic interventions that we are going to, do the management of the patient. So in irritable bowel syndrome, the management is basically the medical management. We have to ease the gut, we have to we can provide the medication so that the diarrhea can be controlled, the constipation can be relieved. So all these things will be done. So first of all, hydrophilic colloids, that is bulk, and antidiarrheal agents are given to control the diarrhea. So to relieve the diarrhea, we have to provide the bulk, that is the fibers. So we can provide the bulk and antidiarrheal agents to control the diarrhea. And anticholinergics and calcium channel blockers are given to minimize the smooth muscle spasm. So as we have seen that spasm can be seen in IBS, therefore the smooth muscle spasm can be relieved by the anticholinergics and the calcium channel blockers. Second thing is we have to initially provide the NPO with a gradual reintroduction of the foods to a healthy high fiber diet. So here in the therapeutic interventions, we have to, reduce the load in the gut. So we have to make the patient nothing per oral. Then we can slowly reintroduce the foods, and we can start from a very low, or we can say the foods that have a less fat and healthy fibrous diet. We have to avoid the foods that trigger an exacerbation. That is, we have to avoid wheat and or gluten. Okay, and we have to avoid caffeine containing products, artificial sweeteners, and citrus fruits. So all these things should be avoided that can lead to exacerbation. Okay, so wheat and gluten can lead to exacerbation. Next are the antidepressants. So in patient with IBS, stress is commonly seen. So we have to give the antidepressant to reduce the stress. So stress reduction or behavioral modification program can be done for the patient. We can provide broad spectrum antibiotic as per prescription. For example, rifaximin shown to reduce overall clinical findings. So rifaximin is useful to reduce all the clinical findings. Allosetron hydrochloride, that is Lotronex, blocks the action of serotonin, decreasing the motility. So we have seen here that serotonin can be seen in the patient, that is increased, and that can lead to IBS. So we can control the serotonin level. So allosterone hydrochloride will be helpful in that. Antispasmodics, for example, chlorodiazepoxide, clidinium, that's Librex, and dicyclomine, that is bentyl, can be given. So this is the medical management of the patient. Now moving on to the nursing care of clients with IBS. So what is our responsibility here? So first thing is assessment. We have to assess the patient for presence of pain, that what is the location of the pain, what is the characteristic of the pain. We have to ask the patient for bloating, for abdominal cramps, because all these are the chief complaints of the IBS. We can ask about the factors that are contributing, for example, food, emotional factor, that is stress, precipitating an event, dietary habits. So if patient eat very less fibers, so this can lead to the constipation. We have to ask history of pattern and characteristics of bowel elimination. We can ask that how many times patient pass the stool, and what is the consistency of stool. All history we have to ask. We have to see the presence of an extent of bowel sound. So we have to check if patient passed the flatus or not, so that we can analyze if the bowel movement is impaired or not. Then if we talk about the planning and implementation, so in planning, we have to instruct the client to eliminate irritating and gas producing substances. So we have to tell the patient to eat low fat diet and high fiber diet. So these are the gas producing substances. So we have to eliminate them. Then we will instruct the client to add fiber to the diet, to schedule the meals regularly so that the digestion has a proper cycle. Chew thoroughly and eat slowly so that there is less load on the gut. Minimize beverages with meals to avoid distension. So whenever we take beverages with the meal, it increase the distension, and also it reduce the hydrochloric acidity. So when we drink water, it reduces the acidity level in the hydrochloric acid, and that's lead to poor digestion. So this should be considered. We can tell the patient to avoid smoking and alcohol because these are the contributing factors, or we can say that will exacerbate the symptoms. We can tell the patient to maintain an adequate fluid intake because this helps in smooth bowel passage, and to perform meticulous perianal skincare. So perianal skincare should be done to be infection free. We can tell the patient to encourage adherence to prescribed medication regimen. So medication should be taken very properly. For example, antidiuretic medication, bulk forming laxatives, and antispasmodics. Patient should be encouraged for the use of stress management strategies. So stress level should be reduced. Stress is seen to be triggering the IBS and the contributing factors. Stress management is very, very important. And emotional reassurance should be provided that the disease prognosis is good and the disease can be reversed into the normal state. So we have to provide the emotional support, we have to clear all the doubts, and we have to provide the reassurance to the patient. So what we are going to evaluate at the end? So we have to make sure that patient reports reduction in pain, patient reports decrease in diarrhea, constipation, patient reports that patient maintains nutritional status, patient maintains fluid and electrolyte balance, patient implements strategies to reduce emotional stress, and patient's skin integrity is maintained. So all these things should be successful at the end. So this will indicate that nursing care was very effective. Moving on to the next condition, that is malabsorption syndrome. So what is the malabsorption syndrome? So as the name indicates, failure to absorb one or more of necessary ingested nutrients. When body is not able to absorb the necessary ingested nutrients, then it can lead to the malabsorption syndrome. It can occur anywhere along the digestive tract. So it is not specific to any organ. It can occur anywhere in the digestive tract. It may be a primary disorders. Okay, so it may be due to the cause in the self. It is not related to any other disorders. For example, celiac sprue or lactase deficiency. So malabsorption can lead to the celiac sprue, in which patient is allergic to the gluten, or patient is allergic to the milk products. So all these things can contribute to the malabsorption syndrome. Or this can be secondary to the gastric or intestinal surgery. It means that it occurred due to the secondary causes, the other diseases. For example, short bowel syndrome, inflammatory disease, infection, radiation, or drug side effects. So all these things can lead to the secondary condition, that is malabsorption. Moving on to the clinical findings. So in patient having malabsorption, as the nutrients are not able to absorb, so the patient will report weakness, fatigue, anorexia, and decreased feeling of well-being. So when there is malabsorption, nutrition deficiency will surely occur. Patient will have low energy level, patient will have loss of appetite, fatigue, weakness, and patient will totally not feel well. Talking about the objective data, so we will find out weight loss due to loss of appetite, flatulence, that is the passage of gas, borborygmus. So this is a very important word. In borborygmus, there are loud bowel sounds. So loud bowel sounds are heard in the malabsorption syndrome. So these loud bowel syndrome, this flatulence will indicate that something is wrong in the gut. Abdominal distension, diarrhea or bulky stool, steatorrhea, that is greasy, bulk, mushy stool with foul odor. So there will be fat in the stool because the absorption is not proper. Clinical findings of deficient protein and fat soluble vitamin intake. Because the patient is having a poor absorption, so they will be deficient in the protein and fat soluble vitamin intake. Dehydration, low serum values, for example, albumin will be low, transferrin, total lymphocyte count, hemoglobin, and hematocrit. All these things will be low. And we can see here that if patient is even taking the good sources of the calcium, if patient is taking good protein, if patient is taking good vitamins, and instead of all the good diet, if patient has all these deficiencies, for example, patient has low hematocrit, which indicates that the blood, that there is iron deficiency or there is hemoglobin deficiency. So all this indicate that patient has malabsorption. Other findings can be lactose intolerance, biopsy of mucosa indicative of pathology. So, biopsy of mucosa can be done to see if there is any pathological history. Deficiencies in the specific absorption test. So, all these are the objective data that we will collect in the patient. Now, moving on to the therapeutic interventions. So, what are the therapeutic interventions that that we can use for the patient? So first of all, we have to resolve the precipitating events. So resolution of precipitating events is very, very important. In dietary therapy, we can avoid of aggravating substances, supplementation of needed nutrients, reduction, elimination of gluten, that is wheat, rye, oats, barley. All these gluten substances should be eliminated because this could be reason of the malabsorption. Intake of celiac sprue because of the deficiency, restriction of the milk because of the lactose intolerance, or enzyme supplementation for lactose intolerance. Tube feedings can be done. TPN or total parenteral nutrition, that is peripheral parenteral nutrition or total parenteral nutrition, all things can be given during exacerbation. So we can see here that all these things are given to meet the nutritional requirement of the patient. If patient is allergic to wheat, then the supplementation will be given. If patient is allergic to milk, then the supplementation of lactose will be given. The TPN can be given, and we have to provide supplements for the needed nutrients. We have to avoid the aggravating substance. We can administer antidiarrheal drugs, the antispasmodics, antibiotics, and vitamins as indicated. So if needed, these all things can be done. Now moving on to the nursing care of the clients with malabsorption syndrome. So what is nursing care we can give to the patient? So first of all, we will assess the patient with malabsorption. We have to assess all the things, all the symptoms we know, all the clinical findings we know about the disease. So first of all, we have to check the weight, we have to check the dietary habits, we have to check the fluid and electrolyte status. All these things will indicate if patient having enough amount of fluid, enough amount of food, and the quality of food that patient is having, we have to check. We have to check the stools for frequency, that will indicate the GI motility and digestion process. The color, because we know they can be steatorrhea. Consistency, because we know they can be diarrhea and steatorrhea. We have to check extent of bowel sounds. We have to check abdominal distension and flatulence. We have to assess the patient for specific deficiencies, example, protein and vitamins. We have to check the presence of fatigue, weakness, and anorexia. We can check the laboratory data reflective of nutritional status. So basically, there is malabsorption syndrome, so we have to check the nutritional status of the patient. Next is planning and implementation. So we can plan the patient, and we have to check we have to monitor the weight of the patient. We have to check the fluid and electrolyte balance. We have to monitor for the clinical findings associated with the cause of malabsorption. We can instruct the client regarding the dietary restrictions and modifications. We have to provide supplements or assist with the PPN or TPN. Now here, one thing that I want to mention, that we are not given with the specific dietary instructions or restrictions because malabsorption syndrome is different for the different person. Some people may be allergic to gluten. Some people may be allergic to the lactose. So dietary pattern or the diet chart depends from person to person. So we have to restrict the things and we have to involve the dietary things according to that. But the basic funda is here that we have to maintain the weight of the patient. We have to maintain the fluid and electrolyte balance. We have to maintain all the nutrients in the body. So we have to provide the supplements if necessary. We can do the total parental nutrition intake. So all these things should be implemented. Next thing is evaluation. So what is the outcome that we require? So if patient maintains or regains the weight, that is the good sign, that is a good prognosis. Adheres to the dietary regimen, maintains fluid and electrolyte balance, verbalizes an increase in energy, and reports decrease in frequency of episode of diarrhea. So all these things will indicate that yes, patient has been recovered from the malabsorption syndrome. The next condition is inflammatory bowel disease, regional enteritis, that is Crohn's disease. So this comes under the inflammatory bowel disease. So in IBS, we can see the Crohn's disease. So what is the Crohn's disease? So Crohn's disease is the ulceration of intestinal submucosa accompanied by the congestion, thickening of some small bowel and fissure formations, fistulas and abscesses may form. So basically what occurs here is that in the intestine, that is mainly seen in the small intestine, there will be ulceration. Due to the inflammation of the intestine, there will be ulceration and that will be accompanied by the congestion there and there will be thickening of the bowel and that will lead to the fissure formations, fistula formation and abscess can develop. So things can complicate here. Now, cobblestone ulcerations along mucosal wall of terminal ileum, cecum and ascending colon form scar tissue that inhibits food and water absorption. So there is a term called cobblestone ulceration. Now, what occurs when there is cobblestone ulceration on the mucosal wall of the terminal ileum or cecum and ascending colon? So that can lead to this scar tissue formation that will inhibit the food and water to absorb. So basically, the food and water will not absorb due to the cobblestone ulceration. Now, why they are called cobblestone ulceration? So what happens if we see this is the intestinal line, then there will be inside the intestine, there will be thick mucus formation on the intestinal wall. They will appear like a cobblestone. So these ulcer will be known as cobblestone ulceration. And due to this much of ulceration on the ileum, on the cecum, on the mucosal wall, and on the ascending colon, so there will be a scar formation. And at that area, the food and water will be not able to absorb. Causes are unknown. Theories include genetic predisposition, autoimmune reaction, or environmental factors. So all these things, that is environmental factors, the genetic predisposition, the autoimmune reaction can contribute to the Crohn's disease. Now here I want to specify that IBS can be of Crohn's disease and second can be the ulcerative colitis. So these are the different things. But here we are talking about the Crohn's disease where there is thick mucus development at the intestine. Now moving on to the clinical findings. So patient having Crohn's disease will complain nausea, severe abdominal pain, cramping and spasm. Exacerbations related to emotional upsets or dietary indiscretions, that is milk products and fried foods. So the symptoms will exaggerate when patient will have stress, if patient will eat fatty food, if patient will eat milk and milk products, fried foods, then these symptoms will exaggerate. And patient will report the nausea, severe abdominal pain, cramping and spasm. Talking about the objective data, so patient we will see weight loss, fever, increased WBC count due to the immune response, Diarrhea with mucus. So mucus can appear in the stool and there will be diarrhea because there is a poor absorption of the food and water. Electrolyte disturbance will be seen obviously because the fluid will be not able to absorb properly. Blood and fat in the fecus can be seen. Enlarged regional lymph nodes can be seen because there is mucus development. So sometimes that thick mucus can rupture and the blood can come in the stool, and regional lymph nodes can be enlarged. Endoscopy with biopsy confirms the diagnosis. So with endoscopy, the thick cobblestone ulcerations or mucus thickening can be seen there. Barium study of upper GI tract reveals stricture of ileum, that is string sign. So when we do the barium study, when we make the patient inject the barium and when the that is the fluorescent dye. So when that is visualized, so upper GI tract will reveal strictures of ileum. So ileum will have some strictures called string sign. So because there is accumulation of the thickened mucus, because we can see here that there will be mucosal wall thickening, so we can see the string sign. So these we can see in the barium study that there will be a string formation in the barium study that we will see. So like this we can see the string sign. And we talked about the cobblestone sign. So this is the cobblestone sign. So these are the ulcers that will appear like the cobblestone. So we have seen here that there will be cobblestone ulceration along the mucosal wall of the ileum cecum ascending colon. So these type of the ulcers will be known as cobblestone sign. Now moving on to the other clinical findings. So fecal fat test determines fat content. Excessive amount is significant in malabsorptive disorders or hypermotility. Erythema nodosum, conjunctivitis, and arthritis can be also seen in the patient. D-xylose tolerance test determines absorptive ability of upper intestinal tract. So D-xylose is a test which will tell about the absorption ability of the upper intestinal tract. And CT scan will reveal the bowel wall thickening and fistulas. So all these investigations can be done and the clinical findings can be confirmed. Now moving on to the therapeutic interventions. So what is the management that we can do for the patient? So talking about the non-pharma management, so we have to keep the patient nothing per oral to decrease the load on the gut, and total parenteral nutrition can be provided when inflammatory episodes are severe. So if the inflammation is severe and if patient has severe pain, and also there is absorption power that is very low, so it is better to provide food through the total parenteral nutrition. Clear fluid diet progressing to bland, low residue, low fat, increased calories, carbohydrates, proteins, and vitamins, especially vitamin K and B12 when large portion of ileum is involved. So here it is mentioned that if the area that is affected, if the ileum that is involved is in the large surface, then we have to provide a low residue, low fat diet so that the digestion process is easy. We have to increase the calories so the energy requirements are maintained and met. The carbs and proteins and vitamins should be provided in enough quantity because we want to avoid the malnutrients, especially vitamin K that helps in the clotting, and vitamin B12 that helps in maintaining the hematocrit level, the hemoglobin level of the body should be given. So we want to avoid the pernicious anemia and we want to avoid the bleeding. That's why these two are very important to maintain. In pharmacological management, monoclonal antibodies form of anti-tumor necrosis factor, that is infliximab, that is Remicade, adalimumab, that is Humira, anti-inflammatory, that is sulfasenazine, that is azulfidine, mesalamine, that is acecol, lialda, pentasa, anticholinergics, that is, various anticholinergics, anti-infectives, that is metronidazole, flagyl, ciprofloxacin, corticosteroids, antidiarrheal medications, for example, loperamide, bismuth subsalicylate, that is pepto-bismol, K-aptopectate. So basically, we want to reduce the complaints of the patient. So for the foreign body, or we can say there is development of the ulcers, so we have to provide the anti-inflammatory drugs, the corticosteroids, the anti-infective drugs, for example, the antibiotics, metronidazole. All these medications should be provided as per the requirement. And if there is complication, surgery can be done, for example, to relieve the fistula, intestinal obstruction. Resection with anastomosis will be done on the temporary or permanent basis. So there will be ostomy done depending upon to the prognosis. And maintenance of fluid and electrolyte balance should be done as well. Now moving on to the nursing care of client with Crohn's disease. So here, first of all, talking about the assessment. So we have to check the weight, temperature, and input and output of the patient. We have to check the fecus for the color, consistency, and steatorrhea. We have to check the tenderness and guarding of abdomen, especially right lower quadrant. We can check for the presence and extent of the bowel sounds. So all these are the basic assessment to check the exact point where the pain is occurring. We have to check the GI motility for the bowel sounds. We have to check the we have to palpate the abdomen. We have to check the tenderness. We have to check the stool for the color, consistency. In planning, we have to encourage the verbalization of feelings because stress is a contributing factor in irritable bowel syndrome. We have to encourage the client and family to participate in Crohn's and Colitis Foundation of America. So here, there is a agency of Crohn and Colitis Foundation of America, where these clients having irritable bowel syndrome or Crohn's disease can participate, and they can have an emotional support. They can be familiar with the patients having same disease. They can have proper education, and all the doubts can be cleared here. Then in the planning, we can monitor the fluid and electrolyte balance, and we can monitor the imbalances also in input and output. We can monitor for complications, for example, increased temperature, increasing nausea and vomiting, abdominal rigidity. We can assist with the TPN if prescribed. We have to teach the client to adhere to the dietary restrictions and modifications. See if ulcerative colitis under inflammatory bowel disease. Tell the patient to avoid taking laxatives and salicylates that irritate the intestinal mucosa. Tell the patient to follow package directions when taking antidiarrheal and mucolyte drugs. Tell the patient to provide skincare if perianal area is irritated, and seek help early when exacerbation occur. And provide preoperative and post-operative care for the intestinal surgery. So basically, we want the patient to reduce the gut function. So the fat food should be low, the dietary restrictions should be done, and laxative should be avoided because that can irritate the mucosa, and antidiarrheal medication should be taken as per the prescription in the proper dose in the proper time. Skincare should be done because perianal area can be irritated due to the bowel having steatorrhea, bowel having blood. So these things should be done. In evaluation, we have to see if patient reports reduction in pain, if patient reports decrease in number of bowel movements, maintains nutritional status, maintains fluid and electrolyte balance, and implements strategies to reduce emotional stress. So if these things are told by the patient, so the nursing care is successful. Now moving on to the inflammatory bowel disease, that is ulcerative colitis. So Crohn's disease and ulcerative colitis are the two types of inflammatory bowel disease. In ulcerative colitis, it is the edema of the mucous membrane of colon leads to bleeding and shallow ulcerations. So here the ulcerations are shallow. They are thin and fragile. So bowel wall shortens and become thin and fragile. Abscess formation can occur. So the main difference between the Crohn's disease and ulcerative colitis is that here the mucous membrane of colon will lead to the shallow ulcerations. So here the ulcers will be shallow. Or in Crohn's disease, the ulcers will be large, the thick ulcer, that is the cobblestone ulcer. The cause can be here autoimmune response, genetic predisposition, bacterial infection, and emotional stress, same as the Crohn's disease. And it can be associated with the risk for colon cancer. So it can lead to the colon cancer. In clinical findings, in subjective data, we can ask the patient will complain with weakness, the patient will complain with debilitation, anorexia, nausea, abdominal cramps. In objective data, we will find dehydration with tenting of skin. So this is a sign where the turgidity of skin is loosened. The frequent passage of the bloody, purulent, mucoid, watery stools, anemia, hypocalcemia, low-grade fever. So all these things will be done. So basically, if patient has irritable bowel syndrome, so the absorption power decreases, patient feels weak, patient feels debilitated, which means that patient feel impaired. There is a certain amount of impairment. There is anorexia, cramps, and that can lead to the deficiency of the hemoglobin, calcium. Patient will have low grade fever and everything associated with the GI functioning. In medical management, first thing we will provide the dietary management. So we have to, during acute episode, the low residue diet progressing to the regular diet will be given. In maintenance phase, high protein, high calorie diet, raw bran may be effective in controlling the bouts of diarrhea and constipation. So raw bran can be given to control the diarrhea and constipation, and we have to provide the high calorie, high protein diet so that the energy level could be maintained. Unrestricted food will be given if tolerated. So the dietary management depends from person to person. It depends upon what the person is able to absorb and what the person is not able to absorb. But the basic funda is we have to rest the GI tract of the patient. So that's why the low residue diet is very, very important. In pharmacological management, antiemetics will be given for the nausea, anticholinergics will be given to relieve the spasm, corticosteroid will be given to relieve the inflammation, antibiotics will be given to relieve the infection, sedatives will be given to relieve the pain, analgesics, tranquilizers, all these things will be able to reduce the symptoms of the patient. Antidiarrheals and anti-inflammatory drugs, that is mesalamine, Acecol, Lielda, Pentesa, olselazine, that is dipentum, sulfasalazine, azulfidine, immune system suppressor, that is azathioprine, that is azathioprine. Immune suppressors will be given because the immune response may start and WBC may increase due to the ulcers. Mercaptopurine will be given, cyclosporine, monoclonal antibodies form of anti-tumor necrosis factor will be given, nicotine patches may be used for the short-term exacerbations. So all these are the pharmacological management to relieve the symptoms. And other than this, replacement of fluids and electrolytes lost with diarrhea, because there is a lot of diarrhea, therefore fluid is needed to be replaced. And total parenteral nutrition may be instituted when patient is not able to absorb anything, and if patient vomit and there is so much nausea. In surgical interventions indicated when medical management is unsuccessful. So in surgical management, segmental or partial colectomy with anastomosis. So the part of the colon will be removed and the ending part will be anastomized. Total colectomy with ileostomy. So sometimes the total colon is removed and ileostomy is done. That is opening of the ileum outside the body. Total colectomy with incontinent or continent ileostomy will be done. Total colectomy with ilioanal anastomosis. Sometimes ileum is attached to the anal, anastomosis will be done, and the colon part will be removed. So creation of ileal pouch that maintains anal sphincter function will be done. In nursing care of the clients having ulcerative colitis, we have to assess the localized area of tenderness found over diseased bowel or palpation. We have to assess the history of patterns and characteristics of bowel elimination. We have to assess the fecus for color, consistency, and characteristics. We have to assess the temperature and weight for the baseline data, presence and extent of bowel sounds, nutritional status. So this is all same as the other diseases. So basic funda is to check if the patient is able to absorb the food, if the area is tender or not, and the weight is lost or not. If there's infections, the temperature will be checked. Fecus will be checked for the fat presence and other things. In planning and implementation, the first thing that is common for all is involve in dietary selections, incorporate preferences such as much as possible. So it all depends from person to person. Initiate administration and documentation of fluid, electrolyte, or blood replacements. Provide gentle, thorough perianal care. Monitor for complications. For example, rectal hemorrhage should be managed. Fever, dehydration, electrolyte imbalance should be seen. Encourage client and family to verbalize feelings and participate in care. Encourage participation in Crohn and Colitis Foundation of America. So as the stress is a contributing factor, so we have to encourage the patient to accept the problem, to help himself, and family members should be encouraged to participate in the disease care so that they have a good insight and a mental stability. Instruct the client to eat small, frequent meals of high protein, high calorie foods, low fat diet to decrease steatorrhea. With vitamin A and E may be supplemented if steatorrhea is present. Avoid irritating food and spices. Take prescribed supplements, example iron, calcium, zinc. Self-administer prescribed monthly vitamin B12 injections because anemia can be seen commonly, so vitamin B12 should be injected to treat anemia associated with ileal involvement, because ileal is responsible for the absorption of the vitamin B12. So that's why it needs to be supplemented if ileum is involved. Avoid all the food allergens, especially milk. Milk may be reintroduced when the relatively asymptomatic. Okay, so once the patient is asymptomatic, so milk can be reintroduced then. If patient is lactose intolerance, it is common and daily restrictions may be permanent. Lactase enzymes can be added to milk products to hydrolyze the lactose. So if patient want to take the milk products, so lactase can be added to hydrolyze the lactose so that patient will not have lactose intolerance. We have to provide initial low residue diet to promote healing, avoid of kernels or seeds that can cause obstruction, increase fluid intake to compensate for losses, and provide emotional support. Involve enterostomal therapy, nurse, refer to local ostomy organizations so that patient has a smooth care. In evaluation, we will make sure that patient maintains or regains weight, adhere to dietary regimen, establish acceptable pattern of soft form bowel movements. Client or family member demonstrate ability to perform ostomy care, implement strategies to reduce emotional stress. So all these things we expect at the ending when the nursing care is provided. If these things are seen, then it means that the nursing care was successful, the medical management was successful. So this was all about this video. I hope that each disease you were able to understand the process, the etiology, the causes, and the management, the nursing care, all these things were understandable. If so, then make sure to like our video, to subscribe to our channel, and share this video as much as possible. And we will see some more disease in this part of the video, that is major disorders of GIT system. So let's meet in the next video. Till then, keep practicing the questions and keep learning new things. Thank you.